Okay, that was quick. Welcome back, and welcome to the first episode of It's No Secret in memory of Tyler Matthews for 2024. As you know, I hope to be seeing all of you a lot more in the months to come. Things are a little different right now with the studio, but we plan to be back soon, and as soon as we are, we will be back on the normal schedule of every Tuesday at noon. So thanks for tuning in. Today, I'm actually super excited and happy to finally have Dr. Rick Barnett in here as my guest today, who, as you've all heard me say many times, I have a lot of faith in and a lot of respect for, and especially when it comes to treatment and just the way you view things. So good afternoon to you and welcome, and thanks so much for coming all this way.
Yeah, I'm happy to be here, and thank you so much for inviting me to come down and have this conversation.
Absolutely. You said you came from a winter wonderland.
Yeah, it's really strange. I came down from Stowe, and Stowe is a famous ski area, but lo and behold, we got our own little microclimate there, and it has been snowing for the last few days, and not a lot of snow, but just that beautiful winter wonderland snow globe kind of look with light fluffy snow falling, covering everything in white. And now sort of driving down here, as soon as you cross over the border from Stowe into Waterbury Center,
Yep.
right by the coffee barn place there and the Evergreen Gardens, it's just, you see lawn, and there's the snow's all gone. And then you get into a little bit closer down to Ben and Jerry's, and then you see more snow there. But the mountains and the ground outside my office and all over town, everything is covered white in Stowe right now. So it's very different than here in Barrie, where you could mow your lawn today, probably.
Yes, I think we could definitely blow some leaves, mow the lawn, do all those sorts of things. Definitely good to see the sunshine, though. Finally, oh my goodness, I felt like it's been cloudy for a month.
Cloudy, rainy. It's been wild.
Yeah. Not nice at all.
It's a good way to kick off the new year, though. We had snow, and now it's cold again, so it feels like winter, which feels good to me. And the sun is out, makes it beautiful. So
yeah, it feels good to me too, and that's what I said this morning. I don't care if it stays 16 all day as long as the sun is shining.
Yeah,
I mean, we need it.
Yeah.
Talk about mental health.
Yeah.
I mean, we really truly need it.
Yeah.
Enough is enough of this stuff. So let's jump into what you do, who you are. I'll let you do that because I'll never do you any justice.
Oh, okay. Sure. Well, yeah, I'm a clinical psychologist doctorate, and I'm a licensed alcohol and drug counselor, and I work in private practice in Stowe, and I've been doing that for a long time. I also run a nonprofit that assists the state of Vermont with the DUI program. It used to be called Project Crash. Now it's called the Impaired Driver Rehabilitation Program. And since 2019, my organization, with a couple of great gals, we have been serving multiple counties in Vermont, helping people get their license reinstated after they've run into some trouble with some driving charges. We provide education and counseling and all that kind of stuff. So that's been really, really rewarding to try to help people. Sometimes, when you go through those programs, it can be very punitive, a lot of finger wagging, like shame on you for getting drinking and driving. And drinking and driving is no joke. I take it very, very seriously. But to hassle people who are already filled with shame and guilt and they can't believe they did this. I mean, some people are angry and rebellious, but a lot of people are really just like, yeah, I messed up. This sucks. I will do whatever I need to do to get my license back. And they're open-minded. And we don't want to make it harder on them by wagging our finger and stuff. So the team that we have, Shayna Lucier, a licensed independent clinical social worker, and Danielle Wallace, she's worked for restorative justice for a while. She's got a master's in restorative justice, and she helps people we all help people get through the program. So that's been really, really positive. I've been doing that. And also it's rewarding for me because I am a person in recovery, long-term recovery from addiction. Ran into problems with the law when I was younger before I got sober. So I know what it's like to get caught up in the legal system, and it really sucks. It really does. And
sometimes you can get trapped there for a very long time.
Yeah. You really can. I mean, and there's good reason why, you know, the legal system is there, and they do make you jump through some hoops. I think there's times maybe where we were just talking earlier where the legal system and the clinical world overlap in ways that can be actually harmful to people. Having the legal system dictate what treatment is required and what terms are required. Again, some of it makes a lot of sense. Some of it is a little bit overstepping, and I think that could probably go both ways. You know, the clinical world could perhaps overstep in some ways with the legal world, but there are ways to improve that. And, you know, like I said, doing this impaired driver rehab program with the state, I believe the state agency that runs that, the folks up there, and our philosophy with my nonprofit align very well. So we work very well together, and that's been very positive. So those are some things that I've been up to. And we also talked earlier that the last 4 or 5 years, I've done a deeper dive into psychedelic medicine research. So research on psilocybin mushrooms, magic mushrooms, MDMA, which is also known as ecstasy. There's some research going on with LSD and some other what's considered psychedelic compounds, like ketamine is loosely considered a psychedelic or psychedelic therapy. And we can talk about that. So I started doing some work with ketamine in my office. People self-administer the ketamine prescribed by a prescriber. And I provide an environment where it's safe and well designed with headphones and eye shades, and people can have an experience and then come out of it and talk about what they experienced. It's not just a place where you go and trip out on ketamine and then leave.
Right, and then leave.
Yeah, yeah. It's more of a psychotherapy based model. So that's been really interesting, really rewarding. I think I have a healthy appreciation for the risks and benefits of that approach, especially when it comes to addiction, because ketamine and frankly MDMA and some of the other compounds, contrary to popular belief, I think they can be addictive, or at least they hold the potential for somebody to misuse those. So I think, again, having a strong sense of the risks and benefits approaching this whole new world of psychedelic therapy, psychedelic medicine and research is really important. It's not like a silver bullet, it's not a cure, but it is, I think, a very useful new approach to helping people with mental health and addictive disorders.
And the research is something that you've done. I mean, that's what you do. You don't take this lightly and just say, you know, these things are available and I'm going to start using them. This is something that you have really worked on for a long time.
Yeah, I've researched it. I haven't done actual clinical research myself. I'm not an institution. I haven't applied for grants or funding to conduct my own research with patients or subjects, but I've done a deep dive into following all the research that's coming out. It seems like every day there's a new research study coming out. And also partnering. I mean, what I mean by partnering with really getting to know personally a lot of the leading researchers in the field from all over the world by hosting psychedelic science and spirituality conferences right here in Vermont. We've done 2 of them so far, pulling in people from, again, all over, from the West Coast, from the UK, and really learning from firsthand sources what their research is all about, what we're learning along the way. And again, offering hope and promise where it's appropriate, and then also being mindful that there are risks and psychedelics may not be for everybody. So we have to be mindful of both sides of it. So when you say, I've done the research and sort of looking at the research, but I haven't actually done clinical research myself. Yeah.
But, and I said this to you before we went live, I have to have a lot of respect for what you do and the fact that you look for these natural, I believe them to be natural substances that could help somebody move forward in a better path. And there are all kinds of things available on the market through pharmaceutical companies that are just as have the same sort of dangers and the same sort of misuse, and you have to have the same precaution as you do with these things. And I always wonder what it will take to get to a point where these substances could also be used or thought of as a, a good part of the process.
Right. Right. Yeah. I think it requires a new way of thinking about it. I think whether it's with mental health medications or those medications approved for alcohol use disorder or opioid use disorder. We were talking before about buprenorphine or Suboxone, methadone, naltrexone, or also known as Revia or the Vivitrol shot. You have meds also for alcohol use disorder. Naltrexone also used for alcohol use disorder. Antabuse or disulfiram, which is like when you take that, you can't drink or else you break out.
Get really sick.
Yeah, get really sick. Or a camprosate, Camprol. So we have medications for some addictive disorders, but those medications, just like medications for mental health conditions, are meant to be taken on a daily basis. So one of the biggest differences, in my opinion, and people don't really realize this until you really spell it out, is that these psychedelic medicines or the experiences that are offered through the use of these psychedelic medicines are not to be used on a daily basis at all. In fact, you can't use a lot of these on a daily basis. Ketamine you could use daily, highly not recommended at all. Some people use ketamine on a daily basis for chronic pain, but for the psychedelic therapeutic benefits, ketamine, psilocybin mushrooms, LSD, MDMA, ayahuasca, ibogaine, all these different psychedelic compounds, they're intended to be used once in a while. And what I mean by once in a while, if you look at the research, let's say on MDMA and psilocybin, people are offered 3 dosing sessions spread out over the course of probably, I think, 6 to 12 weeks. So every other week at the most frequent, probably more like once a month over the course of 3 months. And in between, they're getting psychotherapy. All along the way, they're getting psychotherapy. So these compounds are not intended to be used on a daily basis. You can't develop a physiological dependence to them. It's harder to develop a psychological dependence on them. They're intended to have an experience in which your mind, your brain, your soul allows you to unpack stuff that's buried deep within. So rather than numbing something, rather than covering something up or just trying to stabilize the system, that's what Suboxone does. That's what buprenorphine, methadone does. I saw it in an article recently. It's known as withdrawal therapy. It's another way to look at it. You're managing withdrawal. Are you getting to the underlying root of your addiction when you're taking Suboxone or methadone? Well, in some people, it stabilizes them enough to be able to work on some underlying stuff to stabilize their life. But it really doesn't allow you to necessarily get down to the root cause.
And then some people spend years on one of those medications and then years fighting to get off of those medications because they're not medicines that you can just stop taking. That's something that has to be, you have to work really hard to do that as well. And so the effects from taking those sorts of medications can be just as damning and cause just as many problems. And like you say, they're a Band-Aid for the entire problem. What is really the root of it? And I would love to see a day where we were fighting really hard to get to the root of it and not just putting any more Band-Aids.
Yeah. So there was actually a movie that came out a few years ago called Dosed. And it follows a woman, I think from British Columbia, and she had a serious opioid use disorder. And she was maintained on methadone for a while, but she really wanted to find ways to try to get off of methadone. And again, I'm not saying anything that's intended to diminish the extreme value of methadone or buprenorphine to stabilize people's lives. Clearly, it's very helpful to a lot of people, but there are problems with it. And sometimes people themselves, and I don't think the healthcare establishment does a really good job of listening to patients, because I think far more patients than not go to their prescribing providers or go to these agencies who are providing methadone and buprenorphine, they say, I'd really like to get off of this. Let's work on a plan to get off of this. And a lot of times I think they get pushback from the medical establishment saying, are you sure you want to do that? That may not be a good idea. There's a 93% chance that you're going to die from an overdose if you try to get off of this medication. So why don't we just stay on it for a while and continue to work on da-da-da-da-da. And so I think there are a lot of people who have been maintained on these meds successfully for a while, but they get to a point where they want to come off. And so this woman, she found out about magic mushrooms. She tried those. It didn't work for her. Then she heard about ibogaine, and ibogaine is a unique psychedelic that is less widely available. And you can't be on opioids when you do the ibogaine therapy. Unfortunately, she lied to the providers, and I think she died like 3 times, legally died, or technically died 3 times while she was undergoing ibogaine treatment because she was on high doses of methadone, and they didn't urine test her, and they didn't know that she was on it. So that's very dangerous. But the good part of the story is that she's still sober today. She's been off of all opioids, and it's because of her ibogaine treatment. It doesn't work for everybody, but that's an example of where it's like sometimes up to like 48 or 72 hour experience on this drug.
And that statement alone is it doesn't work for everybody.
Doesn't work for everybody. Yeah.
Is like the big takeaway for me is that there is no one size fits all here. And so it would be amazing to get in a place where we met everybody in the middle, where they were at. What works for you?
Yeah.
Maybe it is methadone, maybe it is Suboxone, but maybe it is ketamine or magic mushrooms or
ibogaine
or one of
ayahuasca
those.
or something. Yeah.
Maybe it's marijuana.
Yep.
We had that discussion too. Maybe that marijuana is what you need to just give you that calm and the maintenance to be able to take a breath and deal and get the help that you need.
Right. But in terms of also a maintenance medication, I mean, cannabis is known to have medicinal properties. It can be a useful tool for some people, even if they use it on a daily basis. And now if you were to look at the side effects or the health risks associated with taking methadone every day as a maintenance drug, or Suboxone every day as a maintenance drug, or cannabis every day as a maintenance drug, I don't know. I think a lot of people would say, if cannabis worked, they'd probably prefer cannabis. And what's wrong with that? Is that now Suboxone and methadone are sanctioned by the medical establishment, so that's okay. But cannabis is not sanctioned in a lot of cases by the medical establishment, so that's not okay, only because that's what the system says. But is that people's lived experience? And I think that message gets lost, unfortunately.
Yeah, it definitely does. And that goes back to even the legal system. It definitely gets lost in the legal system because it's not approved on a federal level. It's still illegal in a federal environment, even if it's legal in your state. And you get into, there's a real tough war there to fight. And
well, it's hard too, because if you throw alcohol in the mix, I know that certain parole and probation requirements, even if somebody's got a drug use disorder or a drug selling charge or some other legal problem that may not even have anything to do with alcohol, they're still forbidden to drink alcohol, even if they never had a problem with alcohol. So that gets confusing, because then you start to look at, well, on some level, I guess it would make sense to mandate those people not to drink alcohol, especially if it is alcohol-related charge. But then does it make sense to prohibit people from using cannabis when cannabis had really nothing to do with any of it, but it's federally legal? I mean, there's all kinds of that. It gets a little, the complexity there is a little tricky. But I mean, I would say, whether it's an unfair comparison or not, if you go head to head, cannabis and alcohol, in my opinion, there's no comparison. Alcohol is far, far more destructive on so many levels than cannabis. So prohibiting someone from drinking alcohol while they're on probation or whatever is like fine. Like it's probably one of the healthiest things you could mandate someone to do.
Right. Yep. Yeah.
Yeah.
And hopefully, I mean, I know that you have also worked hard with that as well, not just cannabis, but in legislation so that you can prescribe.
Yeah.
Let's talk about that a little bit, because I'm a firm believer that, and I said it this morning, I have quite a bit of medical problems. So I have a rheumatologist, I have a neurologist, I have an endocrinologist, I have all kinds of these specialists. And then I have my primary, who was great when I had a sinus infection and an ear infection this week. And but he's not somebody I want trying to help me figure out my MS and pain management and all of that. He's a great doctor, but that's not his specialty. It's not where he's at.
Right.
And I don't want him to necessarily figure out my mental health issues and what it is that I need, what's going to work for me, how to meet me in the middle, when it's just not his area. And I don't mean any disrespect to him at all, but knowing that I could go to somebody like you or many in your profession and having you understand what may or may not work through an actual conversation and understanding what you know about the entire world of it. Maybe it is a medication that's, you write a prescription and you get, let's just say, Zoloft or something. Maybe that's what somebody needs, or lorazepam or something. Maybe you do that, but I would rather know that came from someone like you than just a primary. And I will never understand why that has to be such a fight for you.
Well, it's not. Yeah, it's not just a fight for psychologists to get prescriptive authority. We know historically that any time a healthcare discipline has sought to expand their scope of practice, to be able to do more with their education in the medical realm, the medical establishment has pushed back against that. They often fight against expanding what they call mid-levels or other healthcare practitioners can do, whether it's optometrists, whether it's naturopaths, nurses, physician assistants, all of these disciplines, including dental assistants, even doctoral level pharmacologists, pushing back against anybody who, despite having the necessary training and education, just claiming that if you don't go to medical school, if you don't follow our program of education and training, then there's no way you can safely handle prescribing medications. And that is just so far from the truth, because there's so many different disciplines now at so many different levels of education and training that have proven that they can learn the skills and practice safely and effectively to prescribe medications, psychiatric medications or otherwise. And what psychologists are trying to do with a doctoral degree and then a master's degree in psychopharmacology on top of that, plus 2 years of supervised practice, plus a board exam to prove competence and safety and effective efficacy. We want to be able to prescribe and unprescribe, deprescribe medications when necessary, exactly like what you said. Like, who would you rather have prescribing or deprescribing a psychiatric medication for you? Do you want that to be your oncologist? Do you want that to be your gynecologist? Do you want that to be your primary care doc? Do you want it to be a psychiatrist? Do you want it to be a psychiatric nurse practitioner? Do you want it to be a psychologist with this additional training? I mean, it's a worthwhile question. And, I list off some of those disciplines and you say to yourself, well, a psychiatrist, yeah, of course, a psychiatrist, they're trained. Right. They should be able to prescribe psychiatric medication. A psychiatric nurse practitioner, yes, I think a psychiatric nurse practitioner should be able to prescribe psychiatric medications. But what about a family nurse practitioner or a physician assistant who has no mental health training? These are all, even a primary care doc who's got very little training in addiction, in mental health. The issue is that they have...
And sometimes pharmaceuticals. I mean, I've been prescribed a medication before that had a major conflict with another medication that I was on. Thank God the pharmacist, who that's what he does, knew better.
Right, and that's the thing. Even pharmacists who are seeking prescriptive authority are being blocked. Now, these are like, in my opinion, if you have a doctoral degree in pharmacology in pharmacy, I mean, you spend 4 years plus looking at all the medical conditions people have, all the different medications they can take for all kinds of conditions, and you're just studying for 4 years all the interactions and stuff. Those people are so well trained; they know that stuff so, like, they know it cold, and yet they can't prescribe or de-prescribe psychiatric medications because, again, the medical establishment pushes back against it, and that's crazy. I think the argument that you're putting forth, because you said use yourself as an example. I've got a neurologist, I've got an endocrinologist, I've got all these different specialty subtype providers helping me out with my different medical conditions. So the pushback from physicians says, if somebody like you has all these complex medical issues, is it really appropriate for somebody who's mental health trained specific to be able to collaborate with your physicians and with you to figure out what psychiatric medication might be useful to you? In my opinion, yes, 100%. Because my training as a doctoral level psychologist with a master's degree in psychopharmacology trains me to look at the entire system, not just your mental health, but to understand diabetes, cardiovascular illness, all kinds of different medical conditions that people struggle with, and to know what medications are commonly prescribed for those conditions.
Mine does work with my physicians because I have given that permission myself, and I have said I want this shared interaction. And so, but that's me fighting for myself, saying no, this is, when it comes to this is who I want on my team and in my corner.
Right.
And so they always at least hear her out.
Yeah.
Have they always agreed with her? Not necessarily. But then again, you can self-advocate and you can really push for yourself. I just think it's a shame that we have to, because not everybody is willing to do that for themselves. Not everybody knows how to, or even that they can.
Right.
And I guess I didn't even necessarily know that I could. I just one day said, this makes no sense to me, and you're telling me that I shouldn't take this, but I should take that. And I don't know, because if she's telling me to take it, then that's what I want to do, because that's what she does. That was her recommendation.
Yeah.
And she couldn't prescribe it herself. It was just her recommendation. And but in the doctor I had disagreed.
Yeah.
But he had to agree to disagree, because that's the route I went, and that's my choice.
Yeah.
But it doesn't always work out that way either. They can still refuse to listen or prescribe or have the interaction, no matter what you say.
Yeah.
Yeah.
Yeah, so
it's shameful.
It is. It's a really difficult situation, and again, I can understand up to a point the valid concerns that people who hear about this on the surface might put forth. But if you actually understand not only the history of how healthcare has evolved in terms of different disciplines and the different training models that are out there, that it actually is possible to learn a level of skill and competence to be able to prescribe medications in a safe and effective way, even if you don't go to medical school, even if you don't go to nursing school. There, especially now, I mean, Raylene, the amount of information that's available at our fingertips, the amount of ways that we can learn now, the different training models out there. I mean, to argue for some, archaic, old school, this is the only model in which you can be trained to learn something, it's like, that is long gone. We live in a different time now.
Yes.
So there are ways to learn things effectively, safely, and prescribing psychiatric medications is one of those things that can be learned by a diverse group of people, and it doesn't mean you have to go to medical school. So that is a fight that I've been fighting now. We're going on 8 years. There is a bill in the State House again this year. Yep, this is the 8th year, and we have support from some key people. And I know the medical establishment, the Vermont Medical Society, and some other folks are probably going to push back like they did last session, but we're going to keep trying because it's a valuable thing. And it's not as though there's a lot of people like myself who've gone on to get that additional training, but if you build it, they will come. And there are 6 states. Actually, there's 6. Colorado just joined 5 other states to become a state in which people with my training, my credentials, can prescribe or de-prescribe psychiatric medications. I'm not ready to move to Colorado just yet.
Thank goodness.
I'm a Vermonter through and through, so I'm going to stay here probably. But it's tempting because if I can practice to the fullest extent of my education and training, but I can't do that in my home state,
right?
And I want to help more people, then to go somewhere else.
As you said, I mean, times have changed dramatically, and we are in a world where we're constantly saying we need to meet people where they're at for so many different things: education, work environment, having people be able to work from home, and moms and adjusted schedules, and all of these things that we are willing to meet people where they're at. And this thing that could really, truly change so much and help so much. Roadblock.
Roadblock.
Every time.
Well, we've got Topper McFawn, who's the representative here in Barrie. I think
Yes,
he supports us, and the House Health Committee is interested in taking it up again, I believe. And so to have some representatives and some senators who are understanding that this is basically just a turf war, and we're not meeting people where they're at when we're fighting against this. We've got some good strong headwinds. I mean, not headwinds. We've got some winds at our backs, hopefully, to move into this. And it's interesting talking about psychedelic medicine too. I have heard from a psychiatrist friend of mine that there's a rumor going around that one of the reasons why I'm pushing so hard for prescriptive authority is so I can prescribe psychedelic medicine. And it's like, that is not why I got into this in the first place.
Right.
And prescribing psychedelic medicine is like a one-time, because it's not something you need to do every day.
Right.
So it's not really that big of a deal to prescribe psychedelic medicine. So I'm definitely not in it.
Right,
for
and
the
it's an
psychedelic
entire
side.
therapy.
Yeah.
That's the part that that I find most intriguing, is the fact that it's an entire treatment. You're not only taking this prescribed medication of sorts, but you're getting the help that you need to get while you're taking that. It puts you in a place where you can open up and dig deep and work on the things that maybe you've been too afraid to work on prior to.
Yep.
And it's not a long-term therapy. It's not a methadone. It's not a daily dose. It's not what it is.
No,
And
in fact, so much of it is actually preparation for the experience and integration after the experience. The experience itself is just a 6 to 8 hour. Well, if it's ketamine, it's shorter. But if the way the research is done with MDMA and psilocybin, it's like a 6 to 8 hour experience. But that's just two, 3 times. But you're getting all this therapy before, during, and after. So the actual medicine experience itself, or even though it's a catalyst for change, it's a really powerful experience itself. It's really not the whole focus. The whole focus is, how do you prepare for this to optimize the experience, get ready for it? What are the issues that you want to work on? And then after you have the experience, like, what came up for you? What are the new perspectives, the new understandings that you got from this experience? And how do we help you integrate that into your day-to-day life? Because again, you can't just be tripping every week, thinking you're going to heal from some trauma by, taking MDMA every day. It just,
Right.
or
That's
every other
not
day.
gonna work.
It doesn't work that way.
Right.
Yeah.
But it's meeting people where they're at, and it's literally getting to the root of the problem, and agreeing that, okay, as a part of this therapy, this is what the main focus is to let's figure this out, and let's figure out a plan, and this is going to help us get to that plan.
Yeah. It's interesting. We were talking before too about, when you talk about psychedelic drugs, psychedelic medicines, psychedelics in general, since I'm so deep in the field and studying the research and understanding the clinical applications and stuff, I'm very sort of biased in my perspective, but the wider perspective, as you know, Raylene, is that psychedelic drugs are seen as, hippy dippy,
Oh, yes.
trip your face off, like goofy, eat a bunch of mushrooms and go to a concert. And people think like therapeutic, like what is therapeutic about that? Like, who would want to take mushrooms and lay on a couch in a therapist's office and with eye shades on and stuff? They don't. It's like the most foreign concept for so many people. Still, most people listening to this, most people who think about psychedelic drugs, they think about the Grateful Dead, they think about tie-dyes and hippies and campfires and stuff. And there's nothing wrong at all with using psychedelics in fun and recreational ways or celebratory ways. Nothing wrong with that, but that is not what not what we're talking about here. They're talking about a very clinical, a very deliberate, intentional process for healing and dose. Yeah, like what your dose is. You don't just like grab a handful of mushrooms and just eat them or whatever. Yeah. It's like a very specific dose, and so I think it's just so interesting to me because I spoke to a friend of mine about a year ago, and I told him what I was up to, and he knew me from high school, and I used to do a lot of psychedelics when I was younger, before I got sober, and he just couldn't believe it. He was like, "What? Like, how are those used like in any kind of therapeutic way? It's just for concerts and fun," and like he just could not wrap his brain around it, and that's what most people still think, and I understand why. That's the stigma they carry.
Mm-hmm.
Yep.
And now, so ketamine, is that a psychedelic also?
Technically, it's not technically falls into the classic psychedelic category. When you're doing drug classifications, it's classified as a dissociative anesthetic. Mm-hmm. So it's used in anesthesia a lot. In fact, my son just got his wisdom teeth pulled, and he was given ketamine as part of that procedure. So it's been used in medicine for a long time.
And I know that they use it sometimes in Alzheimer, dementia patients at the end of life. Sometimes it's used in end of life care.
I guess so. It could be used as part of the palliative care medicine protocol. Actually, I haven't heard that before, but I'm sure along with morphine and things like that.
Yep.
So it has been used in the medical world for a long time, but as of like 2018, 2019, it was approved under the brand name Spravato. Spravato, a nasal spray form of ketamine for treatment-resistant depression. So under specific circumstances, you failed at least 2 different trials of antidepressants, you could qualify to get Spravato out of a specific Spravato clinic. But there's also off-label use of ketamine, and ketamine off-label can be used for anxiety, depression, trauma, even addiction. There's been studies on alcohol use disorder, gambling disorder, so it can interrupt some addictive processes as well as interrupting anxiety, worry processes, or rumination or depressive processes. So even though it's categorized as a dissociative anesthetic and not a classic psychedelic, it does produce at the right dosage level, talking about dosage, not overdoing it to the anesthesia levels, but at a lower dose than that. There's an experience that people have that's very psychedelic. It's very, very much could be autobiographical, could be very visual. It's done with eye shades. It's done with headphones on, special ambient sort of trance-like music, and people come up with all kinds of revelations about themselves, and they can go sometimes days, sometimes weeks after one experience feeling relief from their depression, feeling relief from their anxiety, feeling at peace within themselves. I've had people leave my office at the end of a ketamine experience and say, I feel like I've been bathed in goodness. Someone once said, I don't think I've ever felt that anxiety free my whole life. Again, it doesn't work for everybody, and I know I'm using quotes painting a picture that it's this miracle, drug. People come in and say, I just need a brain reset. I need to wash my brain out and clean it out and reset everything. And it doesn't quite work like that. I think if people's expectations are too high, that can really mess with the process.
I agree.
It's just a tool. It's not a cure. But for some people, I would say, in my experience, people self-administering ketamine in my office with therapy, I'd say about 50% report it to be a positive experience. About 30% will report it to be somewhat positive temporarily, but ultimately still, a lot of work to be done in therapy or whatever. And then about 20% of people, little to no effect. Very few people I've seen have a negative response to it. Very occasionally there's a really negative response to ketamine. But for the most part, it's either positive or somewhat positive, a little bit neutral, and then in very rare cases can be counterproductive for some people. Yeah,
and that's the case with any medication. Again, you can have an adverse effect from insulin.
Yeah,
it depends.
Yeah.
You just everything, every little piece of anything medical is you're learning, and you're learning together.
Yeah,
and so meeting people where they're at just makes the most sense to me.
Yeah.
Whether or not the textbook says that. And it obviously makes sense to you because you're willing to fight every year to try to make that happen.
Yeah.
And thankful that you're willing to do that. But also, as you say, you can't set your goals too high and your sights too high. And I have a machine in my back, a TENS unit in my back. It's implanted. So I have the 2 rods on either side of my spine, and then the machine in my back that there's constant electrical current going through. That's what gives me cessation in my legs and in my feet. And it's pain management. I originally got it for pain management. And many people were like, I want it out. It doesn't do anything. That's because they're looking for 100% or even 80%. And that's what they're looking for in a pill too, no matter, or a drug of any kind.
Right.
They
100% relief.
100% relief.
Yeah.
And you can't get that. And for me, 40%, 50% relief was better than none at all.
Yeah.
And that was the mindset that I had to go into that with, was that, all right, this is going to it's not going to fix it, but it's going to help me on a daily basis. And I can't imagine not having it. Now let's talk about cigarettes. Forget it. I can't quit those. Cannot. Tried. A million times. Totally addicted. Can't imagine. I've tried all of the different things that they say to try. I've done patches and nasal sprays and inhalers and lozenges and you name it, and I have not. But again, probably because I never deal with the underlying issue of why do I really do it anyway. I mean, I know why, because I know when I smoke the most, when I'm upset, when I'm really angry, or when I'm driving in my car. When I'm driving in my car, that's because where I think the most.
Yeah.
And my mind's going a mile a minute, and so I smoke like a chimney because I get myself worked up, probably.
Yeah. Nicotine is definitely...
It's tough.
It's the smoking, it's the toughest. That's why I think... So psilocybin has been looked at for smoking cessation, and there's some studies that show there's an 80% success rate in using psilocybin mushrooms for smoking cessation. 80% is unheard of. What's interesting about some of those studies, one in particular, is that in some cases it's not as though you have a high dose psilocybin experience and the next day you quit smoking. In a lot of cases, something happens during that high dose psilocybin experience and you may not quit right away, but because something occurred to you that was very deep seated during that psilocybin experience, it could be a week or a month or a few months later where you're like, oh, I really do want to and need to and will quit. So there can be a delayed quit time. I think also, I don't know if ketamine's been looked at for nicotine cessation. I empathize with you a lot. I'm somebody who has not had any nicotine in my system for 11 years. I'm 51 years old. So when I was 40, I finally put down nicotine in all of its forms. And at least it's stuck for now. I can say 11 years in, I still think about it on a regular basis. It's it still calls to me on a regular basis, and it doesn't matter what form it's in. It could be the Zins or the all the different vape things that they have, or if I see a deal on Grizzly chewing tobacco or a couple of packs of cigarettes for the price of one, all these things. Every time I go into the store, I'm like, oh, is today a good day to start smoking again or whatever? And this is 11 years later.
Right.
But the way I was able to quit was two things. One is I was able to experiment with different forms of nicotine, and so I would just get hooked on the lozenges, or I'd get hooked on chewing tobacco or cigars, or I never liked the patches because the patches were this like long, steady.
They eat my skin.
They're awful. They have this long, steady delivery system where you just have this steady level of nicotine in your system all day, and it just makes you feel like shit. I hated it. I like the up and down, where you're like, okay, now I got the nicotine. Now it's wearing off. So I was able to get hooked on the lozenges, the mini lozenges in particular, and eventually I would start to wean myself off of the lozenges, and then and also the lozenges were easier to sort of like modulate, easier to sort of play around with the dosages and the time of day and all these different things. So eventually I went back and forth for a long time on all kinds of different things, but eventually it was the lozenges, the mini lozenges, and also telling myself that it was a lie. So when you're driving in your car and you're like, my mind is on overdrive, I need a cigarette. And if you're able to catch yourself in that moment and say, whatever I'm telling myself right now about why I need a cigarette, it's a total lie. Then I can call myself out on bullshitting myself. And I can't tell you how many times in 11 years my brain has come up with the most ridiculous excuses
to have one.
I mean, the most ridiculous things, and I can't even. They're hysterical at some point. But because I could catch myself and tell myself, "Wow, that is one ridiculous lie after." Yeah, that's a really good one, Rick. Yeah, that's a great reason to go back to. So I think telling myself that's a lie and being able to do that repeatedly, even now when I go into the store and I see like Zins or some other product, I'm like, that probably isn't as harmful for my lip as this other thing. I should be able to try that. Maybe I should just do it for a little while and I'll quit again at some, like all the different things that come up. I'm just like, no, I don't want to get back on that wagon again. That's no fun.
It's hard. And really when I talk about addiction, and it makes it a little bit easier to understand, because I know that I couldn't just stop doing that today. There's no way that I could just say, no, I'm never going to do that again.
Yeah.
And not without some work.
Yeah.
I need to
it's
work
hard.
on
Yeah,
that.
It's hard.
And it's a lot of work.
Yeah.
And sometimes it's hard to do work. I mean, we already are exhausted with so many things in life that it's just one more thing we have to work at. But it's what the cold hard truth is that it's all work. It's tough work.
It is tough work. Yeah.
And unfortunately, we have to participate in that work.
Yeah. I know. I mean, it reminds me of like this, biological, as human beings, I think we're like hardwired to seek pleasure, avoid pain, and conserve energy. And when it comes to quitting smoking or quitting nicotine, you're increasing your amount of pain, you're reducing your amount of pleasure, and it's really hard. It's not easy. It's like the opposite of conservative. You have to work really hard to stay on top of all the cravings and all the bullshit that you tell yourself. So I think it's kind of what makes all addictions very difficult to overcome, but nicotine in particular, it's like as soon as you try to keep nicotine out of your system, immediately you go into withdrawal. It's very painful. There's like no pleasure in life anymore, and it's just really hard. It's just like one of the hardest things you can do.
It is hard. And my doctor, he said once you turn 50, it's harder and harder to recover from the effects of it, and you really have to try. So I said, okay, at 50 I'm going to do it. And then I didn't do it at 50, and 51 I didn't do it. Now I'm going to be 52 and I'm still smoking.
Yeah.
and I've cut way down, and then I go right back to it.
How now? What's the longest, if any? What's the longest amount of time you've had no nicotine in your system?
9 months
9 months
during pregnancy.
During pregnancy, yes. It's so funny because women can do that when it's a lot of, not all women, but some women can really, knuckle down and say, look, I'm pregnant. I'm not going to smoke during this time period. And for some reason they can do it then. But I guess there's so many other hormones going on and so many other pressures. But I mean, 9 months. Have you had like a week or 2 weeks or anything else other than that?
When I was hospitalized, when I had my foot amputated, that's the only other time.
Oh yeah.
And I didn't have nicotine patches. I didn't have anything. I went just literally and had this done. I was in the hospital for a few weeks, and I didn't do it.
Mm-hmm.
But as soon as I got in the car,
give me a cigarette.
Yes,
Yeah.
like literally, I was like, "You better bring those when you pick me up."
Yeah.
And I meant it too.
Yeah.
I would have been pissed otherwise.
Yeah, it's hard. It's hard.
I
know.
Absolutely no control when it comes to that, and it's tough.
It is.
Yeah.
I know all about it. It is possible though. If I could do it, you can do it.
Right.
I started smoking when I was 10, so I had it like sort of ingrained into my neurobiology. Nicotine is like part of my brain makeup at this point. So to not have it is still like, ugh.
Yeah.
So, but I can do it. I've done it for 11 years. I hope it lasts. I've heard so many stories about people like, oh, I made it 10 years or 15 years, or I didn't smoke for 20 years, and then they go back to again. I'm like, oh God, I hope that's not me.
Yeah, I hope not to. I hope you can stay away from that. But thank you so very much for coming in and talking to me. And I hope that things go much different in the legislature this year.
Thank you.
That it just makes sense. It just, at some point we got to start doing things that make sense, and not just because a book says it or something that happened, like you say, hundreds of years ago when this textbook was written.
Right.
This is what worked.
Right.
We're in a total different time, and we're facing huge new crises. We have people dying of overdose every day.
Mm-hmm.
Far too many.
Yeah.
And crimes being committed, people seriously being hurt, families going through hell.
Suicide rates going up to the roof still.
Through the roof.
Yeah.
And we really, really need to start meeting people where they're at. And I thank you a ton for continuing that fight to make sure that we can do that.
Thank you. Thanks for having me. It's good to talk.
Yeah, absolutely. Thank you all for tuning in, and join JD and I again tomorrow morning at 9 o'clock for another amazing episode of Shits and Giggles, of course. And then we'll catch you here on It's No Secret in memory of Tyler Matthews real soon. Thanks for watching, and have a great day.